It's interesting. Ty was commenting about 10 years ago, probably most of the live cases would have been carotid stenting, and there would have been a good smattering of renal stenting in there along with it. And clearly, the time has changed. So what we're going to be talking about now is renovascular hypertension and the three questions there that you can see that I've been assigned to answer over the next 15 minutes. I'd like to start out by just asking the question, is this even relevant? Is renal stenting extinct? And one of the things which I think is the sad state of affairs in 2014 is our fellows now in interventional programs have more experience with left main coronary artery stenting than they do with renal stenting. It's not inappropriate that they're learning left main stenting, but the sad thing is that there is a starting of a generation that will be lost with good technique for doing renal artery stenting, and I really think that that's a tragedy. You can see it pretty graphically on this slide. So what you can see here is that with the popularity of renal stenting, which really seemed to kick up in the early 1990s, there was a rapid rise, and this was the era when this was a very common topic at many of the symposia, very much like this. Peaked around 2006, and then with a number of trials that I think were counterproductive, we've seen this precipitous drop in renal artery angioplasty and stent placement in the United States, and I'm sure that if we extrapolate from 2009 to 2014, it's gotten even worse. So I think when we discuss renal artery stenting, the answer that we get is completely dependent upon the question that we ask. So as an example, if you ask the question, does renal artery stenting work, you'll get one answer. And we're going to show a couple of examples of the answer to that question. If you look at it in a more global perspective, if you say that in a population, is renal stenting better than optimal medical therapy? This has been the question which has been addressed in two terrible studies, Astral and STAR. One good study, Coral, but I don't think that Coral really gives us the final answer. And even finally, I think that the most pertinent and the most helpful question from a standpoint of a patient, and therefore the caring physician, is what patients have the best chance of improvement with renal artery stent placement. So addressing the second question, and that is renal stenting, obviously plus optimal medical therapy, better than optimal medical therapy alone? That is the question which was addressed in Coral. I'm not even going to talk about STAR. I'm not going to talk about Astral. Terrible trials. Coral was a well-designed trial, but I'd like to point out a couple of things about Coral. First of all, Coral screened over 5,000 patients, enrolled less than 1,000, so more than 4 out of 5 patients were not enrolled in Coral. And obviously that is a characteristic of most trials, but that also affects the outcome of the trial. And I would just make an editorial comment. Chris Cooper, who's the lead author in the New England Journal paper and the presentation at the American Heart Association, is also my partner. So we were kind of ground zero for the Coral trial. And I would get calls from referring physicians saying, listen, I got this guy with renal artery stenosis. I don't want him randomized. I want him treated. So if you say that you're going to randomize that patient, you can pretty much guarantee that that will be the last patient that you ever receive from that referral. So we stented those patients, and that obviously has an impact on the outcome of the study. One of the things that was unique about Coral is that instead of just looking at blood pressure, it looked at all of these clinical endpoints, which frankly are very much more important to the patient than is a blood pressure reading. So from that standpoint, the study design really made sense from a patient standpoint. And when you look at these clinical events, what becomes clear is that when patients are treated with optimal medical therapy, with or without stenting, and then those arms are compared, you can see that the two arms almost lie on top of each other, so that in practical terms there is no additional benefit from stent placement over optimal medical therapy, at least within the confines of the Coral trial. One exception was with blood pressure. So you can see here that the stent arm, which is the blue arm, did in fact have a significantly lower blood pressure in follow-up than did those patients on optimal medical therapy. So I've answered the second question first, at least as far as Coral can answer that. I'd like to back up now to the first question, that is, does renal artery stenting work? So I'd like to start out with this patient, 74 years old, presents with refractory hypertension, which had already led to a stroke. He was on 5 antihypertensive drugs, and despite that, his blood pressure was 204. Bob Hamilton, who was an astute nephrologist, thought, all the non-diagnostics, non-invasive studies are inconclusive. I want an angiogram. So the angiogram showed critical bilateral renal artery stenosis, for which he received bilateral renal artery stents, and the next day he was on no drugs and was normotensive. I think we have an answer to whether in selected patients renal artery stenting works. And then Chip Boddy, who's one of the guys at Riverside Methodist in Columbus, gave me this case. Patient presents with renal failure, heart failure, fluid retention, no urine output whatsoever. Renal artery stenosis was suspected. Here you can see this dated angiogram, but nonetheless very clear that there's an occlusion on one side, high-grade stenosis in the other, stent placement, recanalization. This picture was taken in the cath lab holding area of her Foley bag now filling up with urine. There's no question that renal artery stenting works. And so if we are going to use this technique, we have to figure out when to intervene, and obviously in order to intervene, we have to first diagnose it. So I think everyone in this room could probably recite this list from memory. These are the characteristic findings of patients who are likely to have renal artery stenosis. All of these serve as clues for who might likely be a person with a severe narrowing. And then as far as the diagnostic strategy that we have, there is nothing that beats a skilled tech with an ultrasound machine. So if you have an inexperienced tech, all bets are off. If you have a real obese patient with a lot of bowel gas, all bets are off. But if you have an adequately prepared patient and a really good tech, you will get really good information. You can see the criteria that are kind of the lowest bar for making the diagnosis. But clearly, the higher the peak systolic velocity, the more confident that you can be that there is, in fact, renal artery stenosis, like this example here with nearly 500 centimeter per second peak systolic velocity. If ultrasound is not so good, there are alternatives with their upsides and downsides. CTA and MRA give great anatomic information. They can tell you if there are accessory renal arteries, but they give you no physiologic data, unlike duplex. And MRA is notorious for giving artifactual stenosis information. And you can see the list of studies that are no longer recommended based on the fact that they have been surpassed by these other more useful tests. So when we intervene, first of all, the first intervention in all of these patients should in fact be medical therapies. So you can see a group of 4 different types of drugs, all of which have been shown to be effective in renal artery stenosis. Obviously there can be trouble with the angiotensin converting enzyme inhibitors and the ARBs in bilateral disease. Certainly in unilateral disease they're recommended. And then lipid lowering therapy is certainly standard, and that was part of the CORAL trial. One of the things to emphasize is that AstralStar and CORAL have not changed the guidelines published in the Journal of American College of Cardiology for the treatment of peripheral arterial disease in general and renal artery stenosis in particular. So all of these, accelerated hypertension, resistant, malignant, hypertension with unexplained unilateral small kidney, hypertension with intolerance to medications, progressive kidney dysfunction with bilateral renal artery stenosis or solitary renal artery stenosis, recurrent flash pulmonary edema, and unstable angina attributed to renal artery stenosis, those remain as either class 1 or class 2A indications for renal artery stent placement. So not everything has changed. So what therapy to choose is one of the other questions that I was posed with. This is an ancient study now, 21 years old, and yet it's never been surpassed for its value. This is a study that Jerry Doros did, looking at the blue bar showing the peak gradient and the percent stenosis at baseline. Then the the green bar showing what happens after balloon angioplasty, and finally after stent placement, the peak gradient and the percent stenosis are hammered down to just about 0. ago. So if you're going to treat, obviously the best treatment is a stent. And what we know now is that really we have two very good option classes. Cobalt chromium alloys and stainless steel are great for accuracy. They're great for radial strength. You can argue one versus the other, but they're both very adequate for renal artery stenting. One thing to keep in mind is always go as big as you possibly can. For the initial result, the reason is a better clinical outcome. There have been trials of drug-eluting stents, both larger stents designed for the renals, which turned out to be a negative study, and coronary drug-eluting stents, which simply lack the radial support to be effective. So at least for now, there is no benefit seen with the drug-eluting stents. PTFE-covered stents really are attractive. But here's one of the problems. The Artisan trial, which uses the latest iteration of a PTFE covered stent, is a great trial, great stent. The problem is that the enrollment criteria are so strict and the enthusiasm for renal stenting is so low that we, University of Toledo, are in a 12-way tie for last place for enrollment in this trial, all at 0. It is very difficult to enroll. The only person who is superhuman and can enroll more than 10 patients is Chris Metzger, one of the speakers here, who somehow managed to enroll 12 patients in this trial. I can assure you that a decade ago, the numbers would have been much, much higher in this trial. In talking about therapy, is there a role for embolic protection? Well, no device has been designed for the renal arteries. The AngioGuard was kind of modified for use in the renal arteries and has been tested. That was what was tested in the RESIST trial, a 2x2 factorial trial. Distal protection or none, abciximab or none, looking at GFR. The only group that showed an improvement was with AngioGuard and abciximab, relatively small trial, and this has not translated into common practice. The distal protection device does add cost, it adds complexity, and there's no question that you can dissect a renal artery with the device. Fibernet is attractive. It has been tested in some prospective series. One of the nice things is it has a very small footprint, and so there is at least a potential advantage to using the Fibernet as opposed to the basket type of devices, which take up more of the space in the renal artery and sometimes do not protect side branches. A few words about doing the technique that I think are appropriate. In this day and age, it's actually quite easy to do with radial artery access, which carries all of the benefits of early ambulation and reduced bleeding risk. Here you can see a 125 French multi-purpose guide catheter from the radial, critical renal artery stenosis, balloon stent. You're done, and the patient is sitting upright immediately after the procedure. Also an important technical feature, and again, this is something that I'm concerned that our current generation of fellows may lose, the no-touch technique. 035 wire keeps the guide catheter off of the ostium until the wire has already been placed into the renal artery. At that point, the 035 wire is withdrawn, and now the guide catheter is directed towards the renal artery. Thus, you don't scrape plaque into the renal artery, and you decrease the chance of distal embolization. What to expect? Well, there are plenty of prospective series now that give us a pretty good idea. If technical success is not well over 95%, you're doing the procedure wrong. Should be pushing 99%. Blood pressure improvement will be seen in about 2/3, but a cure will be distinctly rare, that being 140/90 or less on no drugs. And renal function should be stable or improved in over 2/3. What to expect also is how to predict what's going to happen in an individual patient. This remains the great unanswered question. There is no test that reliably predicts the clinical outcome, not resistive index, not BNP, not angiographic percent stenosis, not translesional pressure gradient, whether measured with a catheter or a 14 thousandths wire, and whether stimulated by papaverine or dopamine or not. In-stent restenosis occurs in about 15%. The best way to prevent it is to use a big stent, and this is followed up by duplex ultrasound. We don't really know how to treat it, although PTFE-covered stents really look promising. So to summarize, medical therapy is adequate for many patients with renal artery stenosis, but when it's not, I think we still have a great technique in renal artery stenting that's effective in a large number of patients. Thank you.